privilege to invite Dr. Jitendra Jethani to speak about the complex issues of myopia management. The first three talks would have confused you a little bit. I think now we are here to overwhelm you a little bit more.
I think my talk will confuse it further because I think one of this, just start with the slide. So I think this is one of the slides which we see most in, this is a slide to scare everybody that, myopic epidemic, pandemic is going to come, the sky is going to fall. And this is the Indian scenario. Why I am talking about this is the data. Two of the articles are by Dr. Rohit Saxena. And this was part of my PhD thesis, part 1. So what are the complex issues in myopia? One of the most important point in myopia is not just myopia. We talk about myopia. Myopia is very simple. Myopia is very simple, very easy to diagnose, and very easy to treat. So most of the ophthalmologists were doing it over a period of almost 200 years. Now the complexity arises. The first and foremost part which makes this complex is understanding the progression. Who will progress? That is the crux of what makes it complex. Who is going to progress? Which patients are going to progress? The peripheral refraction which Jyoti showed, so there were bulk of the patients who were actually having myopic defocus and yet they progressed. And then there were hyperopic defocus patients who progressed. So whether we should be doing peripheral refraction or not, we have no idea. Who will progress? That is the one most important thing. Second are different types of myopia. So whenever we are treating myopia, we should understand that this particular patient has an axial progression and we all have modalities to treat only axial progression. So the point which I am trying to make is about axial progression. Third is pre-myopia. So if you can have a set of points, if you can have a set of questions or set of diagnosis documents which can tell you that this particular patient is going to progress in future, you can actually prevent or stop myopia at a very, very lower level. That would be very, very important. And all of this will also help us in our patients of pediatric cataracts that we operate, pseudophakic patients, they also go into a myopic shift. So bulk of our patients whom we operate less than 2 years of age would go for myopic shift despite the fact that we have removed the lens. So accommodation has got absolutely no role, at least in pseudophakic patients, in those pseudophakic patients, and what to do when you treat them and they are still progressing. So this all has been discussed in most of our lectures. Why myopia progress? Maybe genetics, dopamine, near work, outdoor activities, myopic defocus. And so, this is about genetics. So the risk of myopia increases. We saw Meenakshi madam presented that it increases if one of the patient is myope. So these are all risk of myopia or risk of progression. Now, these are two different things. So you can have myopia, but progression may get affected by it or progression may not get affected by it. So the key message is that if parents have myopia, kids are more likely to have it. They are more difficult to treat. When you give them atropine, they are more resistant and they are more prone to be non-responders. Outdoor activity always makes a huge difference, as Dr. Rohit mentioned that, the bulk of our practice should be to tell the patients that outdoor activity and near work amount of light makes a huge difference. And this was published from the Singapore article. Height increase does correlate with the growth of size of eyeball, and it occurs 2 years before the height spurt. So myopia in premature kids, this is totally different from the normal school going myopia that we encounter. One of the articles which showed that the incidence of myopia was 14.3%. This was Indian study published by Savleen and Jasprit. So this was very interesting. You see, at baseline, infants with ROP had an overall comparable axial length. So there was no axial elongation, there was no problem. At 1 year, children who were treated with laser had shortest axial lengths and least decrease in keratometry. So it is because the cornea did not become flat, and so they mainly have curvatural myopia. And that is very, very important when we are sitting in myopia clinic or when we are sitting in our pediatric hospital and we have a patient, we have to do K reading, we have to do axial length to find out what is causing the myopia. We don't have to just start a myopia, myopia control treatment, because there is no myopic progression. We have to first see whether it is a curvature myopia or not. Good old things, but it just holds today also. A lot of patients we all see where, patients are premature and they have been given atropine for nothing. Their myopia is completely at a different route, different plan has to be followed there. So this is something which we do in our clinic, and we have seen that normally this myopia almost stops by 5 to 6 years of age. Yeah, another complex issue in myopia is the curious case of pre-myopia. So who is a pre-myope? Whether plus 0.75 diopter is a pre-myope or he is a hypermetrope actually. So if there are risk factors, if you have serial axial length elongation when patient was plus 0.75, parents are myopic, and there's a lot of near work, and you have done axial length, and axial length is elongating, and his refraction is actually going down, then you can label them as pre-myopes. But otherwise, talking about patients who have plus 0.5 and talking about them having myopia would be a serious, crossover. So this was something which we published. So what next? There's a lot of work to be done on with newer publications on atropine 0.01% not being very effective in long term. We have to work more on concentrations, more work on pre-myopes exactly with bigger sample size, more work on risk factors and identify who will progress. This is very, very important. More work on pharmacological agents, and I think a lot of work should be done on myopia calculators to predict what and who will be progressing. So we all know myopia prevalence is on rise since last 2 decades. We are more interested in who will be progressing. Near work, screen time, low outdoor, these are all risk factors. So we need more combat strategies, more ways to find out who is going to progress and treat them. So thank you so much for the opportunity. Thank you.
Thank you, Jitendra, for an excellent presentation. I mean, we've gone through all the topics.